Good evening, and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus, and a family physician at the Gateway Family Health Clinic in Moose Lake, Minnesota. I am your host for our program tonight on women's health and female cancers. The success of this program is very dependent on you, the viewer, so please call in your questions tonight or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Michael Kassing, OBGYN specialist with Essentia Health, Dr. Sandy Stover, a family medicine physician and faculty member at the medical school on the Duluth campus, and Dr. Addie Vittorio, a family medicine physician with St. Luke's Mount Royal Medical Clinic. Our medical students answering the phones tonight are Anna Grimsgaard from Grove City, Minnesota, Ashley Jink of Belgrade, Minnesota, and Hannah Stray from Big Stone City, South Dakota. And now on to tonight's program on women's health and female cancers. Good evening and welcome everybody. Dr. Vittorio, why don't you tell us a little bit about yourself and your practice?
Yeah, so I've been a family physician for 12 years now with the St. Luke's system. I trained in the Duluth area, and I see patients at two different St. Luke's clinics. My practice primarily includes patients who are female of all ages. Most commonly, I see women between the ages of 40 and 65.
Dr. Stover?
I'm a family physician from Grand Marais, Minnesota, who's now sort of transitioned to the University of Minnesota Medical School at Duluth. And I'm enjoying teaching medical students, and some of the students are currently answering phones I work with. So.
Dr. Kassing?
I'm an OBGYN physician here in Duluth. I've been here in Duluth for 13 years, and I see patients of all ages and ranges as far as OB and gynecologic care.
Very good. Thank you all for being here. Dr. Stover, just because I didn't wear pink today, I thought about it way too late, and you brought up the indigenous piece of it today. Do you want to talk about that just a little bit?
October 19th is Indigenous Pink Day that is sponsored by the American Indian Cancer Society, and it's an opportunity just to help celebrate survivors of breast cancer, as well as to sort of normalize and bring up conversation so people can talk about and think about some of the screening recommendations and how they can access, good screening care for breast cancer.
Thank you. Dr. Vittorio, we talked a little bit earlier, and as I looked at tonight's topic, I wonder if we shouldn't talk a little bit about women's working with women and working on their health and good health habits.
Yeah.
I know all the time we talk about the pathology, but do you want to talk to us a little bit about women's health and
Yeah, and in general,
wellness?
I mean, women's wellness is somewhat very similar to general wellness, but the biggest things that affect our health in the future are our weight, our physical activity, and then our bad habits of sorts. So when I talk to women about their health in general, we look at where do you fall with regards to body weight, what can you do to improve your diet, to improve your exercise, and to reduce things like smoking, like drugs and alcohol, other things that actually really affect some of our female cancers.
Dr. Kassing, I think in your practice, you're seeing a lot of the pathology. How does wellness and good personal health help in cancer care?
Yeah, well, obviously we know there are risk factors for a lot of cancers. And in general, what we find is kind of a bimodal access to health care. Women tend to seek a lot of health care when they're younger because their parents are bringing them in to do their child visits. And then women tend to be pretty regular when they're having babies. And then there's kind of a gap, kind of a desert, roughly, let's say between the ages of 35 and 50, where women tend to be done or finishing up childbearing, but are not yet in menopause. And so I think we see a lot of patients who are lost to care for 10, 15 years, and then show up in menopause and have missed important screenings, such as pap smears for cervical cancer and mammograms for breast screening.
Sandy, I want to pull way back. As a family doc, you are taking care of children also. So where is a good place to start a young woman, young person, young female person in the walk of life and how they should take care of themselves?
Well, I think I'll echo a little bit of what Dr. Vittorio said, but I think one really important thing is just regular physical activity. It doesn't have to be a huge, weightlifting or doing a really aggressive kind of a thing, but regularly engaging your kids when they're young and being active and walking, hiking, biking. And as we go through the years when we're busy with our own kids, teaching them how to be physically active. But as we get even older, the bone density really is improved by having good bone health all the way up and through teenage years. Teenagers tend to sometimes minimize how much calcium they take in, but staying active, eating foods that are high in the nutrients that we know make us grow good, healthy bones. And then in menopause years is keeping that regular activity up. So it's sort of a lifetime thing that we can do is just walking every day.
And I would say, I guess in my practice, the most important time to engage patients is usually between the ages of 9 and 12, kind of catching girls when they're starting to make some of those body changes, when they're starting to have questions, when they might actually be having some early medical issues, and talking about first body image and then pubertal growth and getting your menstrual cycle, and then on to the later teen years when you start to talk about prevention of STDs, healthy partner relationships, kind of catching people when they're most captive of an audience and they have not sort of solidified some of those bad habits.
And a lot is normalizing things.
Yeah.
Normalizing menstruation, of course, the HPV vaccination. There's a lot that goes on in that age range that Dr. Vittorio mentioned.
You brought up immunizations earlier when we were chatting. Do you want to talk about those just a little bit?
Yeah, so the probably the biggest news in obstetrics recently has been the release of the RSV vaccine. And so as we know, RSV is a infection that commonly affects children and can be a real problem, especially for younger children. So now there is a vaccine that is FDA approved for women that are 32 weeks pregnant to 36 weeks and 6 days pregnant, and it has found to be very effective. So we are pushing, we're going to push that out both at Ascension and St. Luke's here in the near future because we know RSV is a significant infection that occurs here in the wintertime. And Dr. Vittorio, you were mentioning it in the older population as well.
Mm-hmm. So patients with a number of risk factors, heart disease, lung disease, starting at age 60, recommending that vaccine. Talk with your doctor, not only your pharmacist, because your doctor knows your health, and your history better than a retail pharmacist may.
I think one thing with the vaccines for pregnancy that we don't always think about is that it's good for a mom who's pregnant not to be ill during the pregnancy because that can affect the pregnancy, but it helps to prevent issues for the baby once they're born. In that first year of life, you're actually giving your baby some prevention ahead of their birth.
I want to go back just briefly on bone health. We kind of touched on it a little bit, and my recall as an old family doc, I'm old here, is that the years where bone is really placed is during the teenage years and all. How do you two family docs, how do you handle that with your young female patients?
One of the
Because they
things,
like pop.
well,
and
that
they-
was exactly where I was going. So one of the things that is relatively common is kids tend to have higher calcium intake when they're in those years where parents are having more say of what shows up at their dinner table. But as kids get involved in other activities, they're choosing their own foods, they're eating away from home. Pop is the most common drink that teenagers take in, any of the sodas. And there's actually some negative aspects of that for bone health. But it's also the lack of calcium in those years when the bones are building and putting their basics. So once we hit about 30, we have as women, we have about as high a level of bone density as we're going to have. And men too will decrease their bone density over time, but for women, as hormones change around menopause, that can accelerate the change and the decrease in the bone density over time. So the higher you can kind of get it with the exercise and good dietary intake, you're going to have an easier time as you continue to mature into postmenopausal years.
Yeah, and I talk a lot about diet, and I mean, we can give all the calcium we want in the form of pills. People don't like them, they cause constipation. They actually don't work as well as eating foods in our diet that are high in calcium. So we talk about, if you can't get your milk in, can you get in, cheese and yogurt at least 2 times a day? Can you, get in something that maybe has some calcium in it if you can't tolerate milk? So most substitute milk products will have some calcium in them as well. And then we want to catch women when they're in their teen years because their hormones are active at that point. So their estrogen is cycling and is building their bone density. So choosing contraceptives that might sort of promote that versus harm that is a discussion I have with people when they're thinking about a birth control method.
Mike, anything you want to add into that?
Well, yeah, I think the biggest thing that really has changed in the last 25 years is that it seems like 30 years ago they used to willy-nilly just take the ovaries out when a patient was having a hysterectomy or was having pain or a cyst. And we know that that is not the right thing to do. For women's heart health and bone health, ovarian retention is very important. And the average age of menopause is 51. So if we can leave the ovaries in a patient until they are postmenopausal, that is really the most beneficial for them.
That's interesting. I did not know that. So that's been a change over the last, 10 years or so?
Yeah, I mean, it's been a long, ongoing discussion for like 20 years, but there was a recent study, I believe just in January, that really the age of 50 is when you want to start taking them out with less consequence.
And I do talk to my patients who've maybe had previous surgeries before and, ask them, what age did you go through menopause? Oh, I had my ovaries out when I was 32 with my hysterectomy. Well, then we're looking at screening for conditions like osteoporosis sooner than we would at the standard age.
So as long as they're screening, what about breast cancer?
Yeah, and I think it varies dependent on your risk factors. So it's important to talk with your doctor about what your risk factors are. Talk with your doctor about, have you had children, which is a risk factor for certain breast cancers. What is your family history? What is your family history of colon cancer and other associated conditions that are now we're finding are more associated with breast cancer? So starting to have that conversation if you feel like you're at risk in your 20s and 30s is a good idea. Routine screening we start to offer for healthy people without increased risk factors at around the age of 40. There are some women who are very low risk who choose to forego that till a little bit later, but for sure by 50 most women should start having regular mammograms and they should be doing a self-breast exam.
Menopause is about age 50?
Yes, sir.
Somewhere in
51,
that in that area. How do you counsel your patients after they've gone through menopause as far as, so we've talked about breast exams, we've talked a little bit about, DEXA's come in here doing bone scans. What about pap smears and pelvic exams and some of these other studies and colon cancer?
Well, in terms of looking at doing PAPs, generally the recommendation is to continue doing some screening up until the age of 65, and if there's never been a problem up to that point in time, you can make that choice with your doctor to consider that may be the last time you need it. But for women, there's a very nice, well-researched kind of a pathway we take with women, so depending on how their PAPs have been up to time, they may go 3 to 5 years between pap smears. So, we talked about the mammograms a little bit, but what was that other question you asked on there?
The DEXA?
The DEXA.
Yeah.
The bone density scan, there are conditions that women have that certain medications like steroids that can increase the risk. And so some people will start screening for bone density scans before 65, but for the most part for average screening we start at 65 again.
And important conditions like, do you smoke? Did your mother have osteoporosis? Did you have your ovaries out earlier? Are big things to discuss.
How do you handle the hormonal aspects of menopause, and estrogens, progesterone, those type of things, and when do you do that?
It's a good question, because there's been more literature supporting that having estrogen longer can be protective in a number of ways. But there's also the risk if there is a family history of breast cancer that can increase that risk. So it's very much a conversation with a physician on an individual basis. But estrogen can be delivered in a variety of ways. Some women have dryness in the vagina and can benefit from just having topical estrogens in that area. Some women have other conditions that will kind of help balance out in estrogens and progesterones. And so it becomes a kind of a personalized plan that people will talk about with their physician.
Mike, do you want to add into this?
Absolutely. So a lot of it is just based on symptomatology. How are the patients doing? Like Dr. Stover said, vaginal dryness is a very common side effect of having low estrogen. The others are hot flashes, night sweats, and sleep disturbances. and we know that it's when, not if, most women will have these symptoms, and then how disruptive is it to their lives. Some women just breeze through, don't have any issues. Other women say, I'm never going to go off my estrogen. Do they have their uterus? Do they not have their uterus? Because if they don't have their uterus, then they don't need progesterones. So it really is a conversation, with your provider, whoever that may be, of what are the risks and benefits, and what's your family history, and how do we proceed safely.
I have another question, and I'll throw it out to all three of you. I'm taking this from an 82-year-old person. Do I still need to have a mammogram even every year at this age? And as I bring that in, could we expand that discussion of age, and is there an age cutoff? And how are we going to handle, and how do we look at the advanced age people, because there's more to it than just age?
Yeah, and it's a really common question we get. We get someone who's in their 90s who said, well, I still want my mammogram. And it really is individualized. We have, studies and recommendations from major bodies that tell us that at most of the time, 75 would be the recommended cutoff. But that does not take into account the woman's individual health, does not take into account their family history. And I often have the discussion such as, well, the recommendations are this, you are above the age, but my thought would be, if you found a breast cancer, what would you do in that situation? What would you decide to do? If you would consider treatment, even of any kind, you may want to consider screening, maybe not every year, but maybe every other year. But it's all individualized. There usually is a cutoff around, the 80s, mid-80s, where we sort of say, well, the likelihood that you're going to die of a cancer that develops is just not there over the next 10 years. But I would say for women who are between the ages of 75 and 85, we have that discussion.
Yeah, and I would completely echo what Dr. Vittorio said. If you would do something about it, then it's worth doing. If you would not, then I wouldn't encourage you to go through it.
Yeah, and know your limitations. If you are severely debilitated by another disease that is likely to cause major complications over time, you may not want to do cancer screenings any longer.
Question comes in regarding natural, I must change the subject just a little bit, natural progesterone for postmenopausal women. I have no information on that, so.
So there are a number of products that have been put on the market over time to address certain needs. I think when one says natural progesterones, there are some products that are kind of labeled that way, but may not have the delivery in the way that we're thinking. There's the micronized, is what we call it. Micronized progesterones tend to be the best delivered and the easiest tolerated for women. So I think it's that conversation of what is meant by natural.
And I guess you could go online and you could go to Amazon and find progesterones, and some of them are plant progesterones because a lot of living things produce hormones. And I think having a discussion with your doctor, if you are going to go the route of a natural hormone or a compounded hormone or something delivered not via pill, then use a reputable compounded pharmacy, and your doctor knows kind of where those things are. But the reality is they're not any more or less risky, probably, than what we prescribe in pill. They're just delivered differently, and so you might see changes in the amount of concentration of that, or the spikes in the peaks of those hormones.
Yeah, and I would just add that the American College of Obstetrics and Gynecology does not promote any of them. I think that there's a distinction that patients need to make between, is this a pharmacological product, meaning that you get it from your pharmacy where it's FDA regulated, or is it a supplement? And the reason that is important is because supplements are not well regulated, which means if you have a pill that's a supplement, it may have a different amount of medication in it than the next pill would, where if it's from a pharmacy, there is safeguards in place to make sure that you're getting the same amount of active medication in each tablet.
Another common complaint is urinary tract infections in the elderly people. What causes the recurrent bladder infections, and is there correlation with the infections happening during the menstrual period also? That's the other part of this question. It's a two-parter. And I was thinking also menopausal. That's where I was stumbling
Going
through
there.
this.
I think one thing that we think about overall what tends to lead to any kind of bladder infection is if there's retained urine. And so that can be sometimes if something's inflamed the area where the urethra where the urine comes out, and so you hold on to it, you can't completely empty. Or there's some, as we age, there's some things that make it harder for us to completely get that last little bit of urine out. And so when you have pooled liquid, the bacteria can find that and create and lead on to an infection. There's a number of methods and some medications that can help with bladder issues related to, across the lifespan, but it's a little more common postmenopausally, related again to some of the estrogen issues that with a lack of estrogen get more dryness around the urethra and the vagina. And so topical estrogens themselves can be really helpful. So drinking a lot of water helps keep things clean, but you also have to make sure that the system is flowing appropriately.
And I would say your other risk factors as you age are that you don't drink as much water. So you have concentrated urine, you have a vagina that doesn't protect against infection, and your urethra is subplanted right in the middle of sort of your vaginal opening. We also start to have fecal incontinence, and we have urinary incontinence. So the area changes to the point where there is more likely to be bacteria in that area.
And the only thing that I would add to that is that there's nothing here about hygiene. Sometimes there's a hygiene, but overwhelmingly that's not the issue.
Yeah. And I would say during the menstrual cycle, to echo that second part of that question, is we see pH changes in the vagina with different parts of the cycle. And when blood comes into the picture, we see a pH that becomes less acidic. And so our acidic environment protects our vagina against infections. And so that's why we would see an increase in possibly UTI, although I don't know the research on that, but more so vaginal infections.
What can women do to firm up their stool, as long as we're talking about that area?
That's kind of the question is how loose is the stool normally coming, but you can use fiber products to help provide more bulking to stool, so it's easier to control the stools and reduce some of that issue with fecal incontinence.
And that's probably your safest bet, is to.
What causes endometriosis? Switch a little bit here.
So endometriosis, so let's talk about what that is first. That is when the lining of the uterus grows outside of the uterus. Overwhelmingly, it's genetic. There's thoughts about, is it implanted with, if menstruation, do women menstruate out their fallopian tubes? And there's a lot of thoughts, and none of them are really proven, other than for sure we know there is a genetic component to it.
Addie, can a young woman who has had a previous injury to her breast develop breast cancer from that?
I don't know the exact answer. I do know that in the body, when we have chronic inflammation, we see cells proliferate. And so when we see cells actively try to repair themselves, we grow new cells of certain types, and so cancer is more common. But I don't know the exact answer as to whether that would be common. I don't suspect it would be.
Yeah, I don't think that would be a common correlation.
I think one of the hard parts is sometimes if there's an injury, you get a little bit of calcium left over, and mammograms can sometimes pick that up, and that's why we are lucky to have people who are trained just in doing mammograms to kind of help tease that out.
And that's why it's important to get your regular mammogram, because every year that radiologist is looking back and saying, well, Janice had this last year in this spot, so that's normal. And they wouldn't know that if you skipped your mammogram for 5 to 7 years.
DEXA scans, we've already been there a little bit, but when should you get one? How frequent, and what do the results mean? We got about 2 minutes.
You should start just regular screening at 65, but if there's risk factors that, as you talk about with your provider, you might get them done earlier. And every 2 years is about as often as 2 to 5 years, again, depending on risk factors in terms of how often you should have them.
And there's some studies that we should go longer, because we don't see the bone changes until longer.
Yep.
Does drinking, reinforcement now, does drinking Coke or Pepsi increase your risk for osteoporosis?
It reduces the benefits of the foods that help you support and avoid osteoporosis.
Yeah.
But there is some hint that carbonated beverages might be a negative for bone health.
My doctor does a breast exam with my bra on. Is that the correct way?
No. Typically, we would want someone unclothed so you could cover from the middle of the chest all the way up to the collarbone, and then all the way almost to the back of the sides of the undersurface of the underarms. So really, you want to get everything unclothed and take a look and be able to feel all those areas without the bra in the way.
And breast exams, should people be doing their personal breast exams?
There is a recommendation to start them at 40. Breast exams in the clinic, we do them. There's not as much evidence at a certain age that they need to be done, but certainly it is another way of detecting cancer, and there's very little risk or harm to doing them.
And I think you were kind of suggesting the self-breast exam, and that doesn't usually hurt.
No, and I think it's good for a person to understand their body too. So.
Yep.
I want to thank our panelists, Dr. Michael Kassing, Dr. Sandy Stover, and Dr. Addie Vittorio, and our medical student volunteers, Anna Grimsgard, Ashley Jink, and Hannah Stray. Please join Dr. Peter Nalen next week for a program on rheumatoid arthritis, tendonitis, and bursitis, when his panelists will be Dr. Vishua Devala, Dr. Wasim Khan, and Dr. Paul Sanford. Thank you so much for watching. Have a great night.